Hi, this is my second log for Practicum. I'm just going to jump right into the questions. Today I'm going to describe an experience that was significant and maybe changed how I would practice in the future. I mentioned this a little bit in one of our clinical debriefs, but we had a patient who came in who was severely contracted and ended up being on multiple pressors but did not have a DNR. And I was in the patient's room when the hospitalist came in and had a very serious conversation with the wife who was present at the bedside about what what a code would mean for this patient and what it would mean for them going forward, and maybe kind of making assumptions about their quality of life afterwards. Not in a bad way. I think that it was a really needed conversation, but it was really, really hard to sit through. And there had been some talk earlier in the day when the patient's wife left the room about how the patient was ex-military, and so he was receiving disability, like veterans disability compensation, and so she was probably getting a disability check, and that might have been the reason that she wanted him to continue to live and didn't have a DNR for him. And adding, like, in addition to her love for her husband, like, she was benefiting from him staying alive even in his very weak and weakened state, I guess. But the patient was unresponsive. He just wasn't in a good spot, and on multiple pressors at that point. I think the right thing to do was for the provider to talk to the patient's wife about, as his delegate of care, this is not something that we want to have to do to him. But it just made me reconsider how many patients have a DNR and how many don't, and what's the reason behind that. I remember when my grandparents, who are now in their 90s, I found their DNRs in their bathroom a couple years ago, and I got really, really upset because I would want my grandparents to stay around for as long as they possibly can. But I think now, having more experience in nursing school, I can't be upset about anybody having a DNR or having specific wishes for the end of their life, because I would not want my grandparents or somebody else who has lived a long time to have to go through a situation where their ribs were cracked, or I just think that rather than passing that way and so brutally handled at the end of their life, being able to just pass and move on to whatever is next is a really monumental thing. And so I'm really glad that in the moment in Practicum, with the situation with this patient, we were able to convince the wife, and I hate using the word convince, but it really was convincing her that having a DNR was the best course of action moving forward. I really wish that I had been able to follow the care received by this patient moving forward and what ended up happening to him. Not that it would have been very exciting, but I just think that and I really hope that the hospitalist who was with them provided some sort of continuity and reassurance to the family, because they were really grieving, and it was really hard to be there and to also hear these conversations about how she was just there for the disability check. But outside of that, that same day we had a patient who was alert and oriented, I don't think fully oriented, but she was alert and oriented, and was paralyzed from the neck down due to a spinal break or fracture, and so she was in spinal shock, and it was really tough treating that patient as well. This was a tough day overall, but this patient was alert and oriented but couldn't move her arms and legs, and had come into the hospital earlier that week because of a fall, but they hadn't done an MRI or hadn't done an x-ray of her upper cerebral area or her neck or head. And after we saw her MRI, we saw that her spinal cord was severely damaged from the fall that had happened days prior, but nothing had been done since she had like stopped moving, I guess. A little bit confusing, but it was really hard to see this patient who could answer questions and, you know, talk to me, lose this ability to like move her arms and legs and not fully understand what was happening or going on. I think I have really loved and appreciated everything that I've seen in the emergency department, but a big drawback for me is that like continuation of care and like seeing the patient go through the next steps of their care, or like hearing back about how a patient is doing, because a lot of patients we send home, or, you know, some patients we transfer out to either another facility or back to their nursing home or wherever, but or even upstairs, but even if they're transferred to another unit within the hospital, we don't always hear what happens to them. And it's really hard to have that like weighing on your heart that this patient was, you know, experiencing this hardship, and you were only able to provide so much support and care for them until they moved on to the next spot. I don't know, I've been battling with that a little bit recently. Going to my PLOs, I have gone through and kind of checked off what I feel like I've been able to meet. I feel like I've been more ready and like had readiness for emergency scenarios. I don't know that I know the code card completely in and out, but I don't think that's completely my job either right now as a nursing student. I feel like I've been able to remain calm under a lot of pressure or stressful situations, whether it's patients yelling at us to get things done or, you know, a demanding spouse who's at the bedside. I think I've gained a lot of understanding of how to manage multiple patients. Having anywhere from 2 to 7 or 8 patients at a time has been really awesome and very rewarding, being able to manage so many people at the same time. I feel like I've gotten very comfortable with IV insertion, which has been fantastic. I'm really grateful for that experience in the emergency department. I understand the flow of patients from the ED to other units, like I talked about. I'm still being able to pick up those small cues or changes in a patient's status, and I think that's just something that'll grow as I become a real nurse and practice more and more. And I have been doing a lot of small, but like I have been doing a lot of medication administration and specifically IV fluids a lot. I feel comfortable spiking a bag and getting that set up. We don't use a lot of pumps, but when we do, I try to take control and get that practice in. And then finally, my creative piece of this log is that every week I've been contributing to this like suction canister that's sitting at the charge desk, where they ask nurses to, after they've done a medication administration, keep the tops of the medication vials that kind of like pop off and pocket them and then put them in this canister, because there's a nurse on the unit who takes the tops and makes art out of them. And so I thought that was really cool, and so I've been trying to do that as much as possible, even in the emergency department where there's kind of craziness and we're going. It's not hard to like pick up all the trash and then take that extra piece of trash and throw it in my pocket, because we do have so much waste in the hospital, which is really sad. But I pulled up some pictures just for reference. So here's a cool one I thought of some houses, and then they had this like eye on display, or a similar eye I guess a lot of people have done the Vincent van Gogh and other really pretty ones. But I thought that was a really cool art project, and incorporating waste and reusing this thing that we just throw out really quickly into real art that's, could be displayed on a unit somewhere. So just wanted to share that. Thank you so much. Bye.